Hello, everyone. I hope you can all hear me and you can all see the screen with all the participants, presenters, and chair and co-chair. Good afternoon, good morning, or good evening, wherever you are. Welcome to the International Conference on Children and Their Families using the Multiple Indicator Cluster Surveys. My name is Turgay Unalan, Statistics and Monitoring Specialist in the Data Collection Unit, Data and Analytics section of UNICEF, and I will be chairing today's session on health-seeking behavior, curative care, respiratory health, and malaria, and replacing the chair on the original agenda, Ranto, who is joining another session in this conference, unfortunately. So I'm replacing him to avoid this agenda conflict. And my co-chair today is Nazim Gashi. You can see him on the screen. He's our mixed GIS consultant in Data Collection Unit, Data Analytics section of UNICEF. Before I introduce our speakers, a few words of housekeeping. This session is being recorded and will be hosted on the UNICEF Mix website and YouTube channel, as well as on the Bristol Poverty Institute YouTube channel and embedded on the Bristol Poverty Institute website after the event. By attending, you consent to be part of this recording. Please ensure that you have added your name rather than being listed as guests, as we will be monitoring attendees and need to know who is asking our speakers questions. You will be able to ask questions only via the MS Teams Q&A function that you can see on top of your screen. Please insert your questions there using this function, and depending on the time we will have at the end of the presentations, we may or we may not able to answer every question, but we will try to do our best. Also note that the chat function is not available to attendees, and we are encouraged to use the Q&A function to ask your questions. Please be respectful. All events at this conference are being monitored, and we reserve the right to remove attendees whose comments are deemed offensive or derogatory. In this session, we have two presentations, and given that we have 1 hour allocated for the session, each presenter will have a maximum of 20 minutes to present. After the end of the presentations, both of the presentations, we will visit the questions asked and give the presenters a chance to respond. Presenters are expected to share their screens and run their own presentations, but let us know if you want us to share your presentations from our end if you run into any technical difficulty. Other speakers of the session, if they are not presenting, should keep their microphones muted until it is time for them to present. We have two presentations today, and the first one is titled Coverage for Child Curative Care Using Mixed Data, a case study in the Democratic Republic of Congo, and it will be presented by Roland Mady from Johns Hopkins Bloomberg School of Public Health, USA. And the second presentation is titled How Multiple Indicator Cluster Surveys Can Be Used to Assess the uptake and Use of Long-Lasting Insecticidal Nets Over Time in Togo. And it will be presented by Gountante Kombate from University Medical Center Utrecht, the Netherlands. And there will be other co-authors, but Kombate will be presenting the presentation. So without further ado, I would like to give the floor to Roland to present his presentation. Over to you, Roland. Please share your screen.
Okay, can you see my screen now?
Yes, we can see it now.
Okay, wonderful. Thank you, dear chair, dear co-chair, and dear participant. My name is Roland Mady. I'm a research associate from the Johns Hopkins Bluebird School of Public Health. And I'm doing these presentations on behalf of the other co-authors, Dr. Abdoulaye Maiga, Associate Scientist, and Professor Agbessi Amouzou, who is the Director of the Global Disease Epidemiology and Control Program. And this presentation is about effective coverage of child curative care using mixed data, a case study in the Democratic Republic of Congo. And for our presentation, we have 4 parts. The first one about background, the second method, the third one about the result, and then we will have the conclusion. In terms of background, you can say that DRC is a country based in Central Africa, and like a lot of low and middle income countries, this country is facing preventable under 5 deaths, and the main causes are malaria, diarrhea, and acute respiratory infection, and all of them represent more than 40% of the causes of under 5 death in DRC. And we can highlight that the country has a drop in the under 5 death rates. It was in 1990, 185 deaths per 1,000 live birth, and today in 2022, it's 75 deaths per 1,000 live birth. And in terms of neonatal mortality rate, it's around 26 deaths per 1,000 live birth, according to the IGMI estimates. And at this pace, the country will reach under 5 death mortality rate of 58%, according to the IGMI estimate in the year 2023. And this is not meeting the SDG objective for under 5 mortality, that is 25 deaths, as low as 25 deaths per 1,000 live birth. And at the same time, we can have an improvement of coverage of health intervention. So this situation brings forth a question, the question about the quality of care. And the objective of this study is to examine the capacity of health facility to provide curative care services to sick children and evaluate whether they receive healthcare according to quality standards. And to do that, we use different frameworks, the WHO guidelines and recommendation related to IMCI, also frameworks related to health facility survey, like the health HFA and SARA frameworks. We also use the Danubian models to assess the quality of care. And finally, the Amouzou and all effective coverage cascade. And here we have the relation between the health service, the quality of care, the domain, and the variable. And here for integrated management of child illness, for the quality of care, we have 2 components. The first one is service readiness. And for service readiness, we have different domains. And here we can see availability of service, equipment and supplies, and etc. And for each domain, we have related variables that are listed here. And for the service provision, the same applies, and you have different domains here, physical exams, for example, and health history. And for all these items, the score of 1 is considered when the item is available, and 0. And after that, we computed a score for each component of the domains. And after that, and have a whole score for service readiness and also for service provision. And here is the cascade of potential losses of health benefits. And this cascade starts with the population in need, the target population. And you have the health losses that is represented by the green bars here. And among those in need of service, we have those who will visit health facility, and they represent the service contact. And you have those who won't do that because of the different reason, geographical issue or financial issue, for example. And among those who visit the facility, we have those who visit the facility that is ready in terms of having the different services and input they need to perform the care. And among them, you have those who receive the health service, and they represent the crude coverage, and those who didn't receive the health service. And this is called here the missed opportunity. And among those who receive the health service, you have those who receive the service according to the quality standards. And that represent the quality adjusted coverage or effective coverage. And you have those, the ineffective service process, and they represent the process quality gap. And after that, of course, you need to have user adherence and also efficacy of the intervention for health gain achieved. And the data allowed us to go up to the quality adjusted coverage here, or the effective coverage. And when we apply this framework to the different diseases we have to deal with for diarrhea, fever, and acute respiratory infection and pneumonia, we have this framework for population in need. Children experience either malaria, diarrhea, or pneumonia in the last 2 weeks, and care seeking from any source. We have different kind of source. It can be public hospital, private hospital, and also private facility, also pharmacy. And apart from that, we have the service contact for those who visited the pharmacy, health facility or skill provider. And you have the readiness for those who visited a facility that is ready to provide the service. And you have the crude coverage of intervention. For diarrhea here, we have oral rehydration salts. And for malaria, we use malaria test. We should have used the proportion of sick children who were tested for malaria and got the result, but we don't have it available in the data set. So we proceed with the malaria test. And for pneumonia, it's quite difficult to acutely assess pneumonia cases with household survey. So we took the service contact. And for IMCI here, we have it for any of these 3 disease. And the last part of the cascade is the quality adjusted or effective coverage here, intervention performed according to the quality standards. And for the data, we use the DRC Mix 2017-2018 for the household survey. And for the health facility, we use the service provision assessment survey for the same year. In terms of effective coverage, we focus on the definition from the think tank group on effective coverage put together by WHO and UNICEF. And it states like this: effective coverage is defined as the proportion of the population in need of a service that resulted in a positive health outcome from the service. The measurement of effective coverage aims to capture the potential health benefits of an intervention by integrating the dimension of quality of care. And in a nutshell, we can say that the main idea is to make sure that we take into account quality when assessing the coverage or intervention. And to do that, we need to do a linking between the household survey and also the facility survey. And to do that, we use administrative and ecological linking. We use administrative region, facility type, and also the managing authority. On this slide, you can see an example of how this matching is performed. On the left-hand side, you have DRC SPA 2017-2018. And for example, here for the region of Kinshasa, we have public hospital here. And the score from this public hospital will be affected to public hospital in the mix. And we will multiply this to adjust the coverage for the different intervention in the household survey. And the same principle applies for each facility type here. In terms of results, for diarrhea, we have 14% of children who experience diarrhea, and for fever, 28%. For acute respiratory infection, it's 3.7%. And for children who experience at least one of these 3 diseases, we have here 3 to 4 children out of 10. And in terms of IMCI service readiness score, we can see here the overall score is 64%, and this score varies by a component. And you can see that the lowest score are from training and supervision, and also service supplies. And we can notice that public hospital and private hospital got the highest score, as you can see here, the green bar and the blue bar. And for the IMCI process quality, The pattern applies like what we just seen for the service readiness score. And here, the lowest score is at the counseling component here. In terms of result of effective coverage, 35.7% of children experienced at least one of any of these diseases. And we have it here as the gray bar. And among them, 54%, for 54% of them, their parents sought care from any source of provider, your care provider, and 37% had chance to be seen in a health facility or by a skilled provider. And they have to come across with facilities that are not ready enough, only 19%. And those who receive intervention represents 26% for any of this disease. And those who receive intervention according to the quality standard, they represent 10%. And this is a process quality gap of 16% or an inadequate process quality. And we do the same. We did the same for each disease here, and you can have the cascade for diarrhea, fever, and pneumonia. And as you can see here, the scores are pretty low, especially for diarrhea, only 10% for readiness score, for example. And in terms of process quality gap, we have 17% here in diarrhea. That is much more important than the other disease. And you have 13% for fever and 16% for pneumonia. And for equity analysis, we did the cascade also for 6 stratifiers. And the most discriminants are the wealth quintile based on the richest compared to the poorest. And you also have the place of residence and also the education level of the caretaker. And I just want to highlight something quickly here. We can see that the crude coverage is higher for the richest compared to the poorest. And we can see that also the quality adjusted is higher for the poorest, for the richest compared to the poorest. But here we can see a gap of around 20% for richer and 13% for poorest. So we can see that the richer experience a much more gap compared to the poorest here. And to wrap up, here are the 3 takeaways. A substantial proportion of facilities have limited capacity to provide IMCI health services and care according to standards. And children living in rural areas from poor household or home mothers or caretakers have low education level, experience poorer curative service access and quality. And to achieve this SDG, especially for under 5 children, some improvements need to be done, and in terms of service supply, counseling, and providers training. And this component represented the lowest score. And we would like to thank the Bill and Melinda Gates Foundation for supporting this work. And you also are the chair, the co-chair, and the participant for paying attention to this presentation. And we'll be happy to answer to any question at the end of the session. Over to you. Thank you.
Thank you very much, Roland. This was a very interesting presentation and a very good example of linking mixed data with other sources of data based on stratum level. But yeah, this is very encouraging and good example. Thank you very much. For those listening, attending, we encourage you to ask your questions using the Q&A function that you can see at the top of your screen. And please insert your questions there. And then at the end of the second presentation, we will ask our presenters to elaborate or respond to your questions if you have any. So without further ado, I would like to give the floor to our second speaker, Kombate. The floor is yours, please. You may share your screen now. Okay, we can see it. I think you may start. Thank you.
Okay. So thank you, everyone. So as you mentioned, my name is Gountante. So I'm going to share the key result from our teamwork. We did title how multiple indicator cluster survey can be used to access the update and the use of long-lasting insecticide net over time in Togo. So okay, so we are going to show you something about the background, the aim of the study, the method, the result, and also to conclude with a key home message today. So as a background, you know, malaria is a major public health problem in sub-Saharan Africa, and so in particular in Togo, because Togo also is an endemic country for malaria, and child under 5 and pregnant women are the more vulnerable. So for the disease control, so we used a bed net approach, which has been implemented for since 2004 with many mass distribution campaign in the country. And for this study, we said we can access, since it started for a long time, we can access the ownership, the access, and the use for this mosquito net in household population, starting from 2010 to 2017. So it can, at the meantime, it can help us to identify like equity trends among like maybe rural, urban, and also among richest or poorest households. So also at the same time also identify some factor that can influence the use of bed net among children under 5 in Togo. So as method, I mentioned we use a multiple indicator cluster survey 2010 conducted in Togo, and also we also add other survey, population-based survey like demographic and health survey 2013 and 2014, and also the malaria indicator survey, the last one 2017. So I also said we assess 3 indicators: ownership, access, and the use. And we assess the trend during this period, and also we at the end perform a multivariate analysis and to see which factor can influence the bed net use among children under 5, because we said maybe because as they are more vulnerable, maybe we can more focus on that, and it can be also helpful for further intervention conception. So as key result we found, we noticed that bed net ownership, yeah, of course, improved from 2010 to 2017, from 56% to 85%. And also access also improved. Access like having one bed net available for 2 persons in households. So also improved from 28% to 71%. And also the use in population was also increased by 37% to 63% from this during this period, our study period, 2010 to 2017. So also at the same time, we compare the evolution in household population and also in children under 5, and we noticed that there were quite a similar observation in terms of use among children, because you know that children under 5 their use depend on their caregivers or mothers. So, okay, we also assess the spatial and temporal variation. And you can notice that, as I mentioned in the previous slide, you can notice that in each square, you can see each square represents indicators, you can notice that each square, like the A is for ownership, B is for access, and C and D is for used. C is among population, and D is among under 5 in households. So you can notice that in each square, the last map is very darker than the first one because there is like a kind of evolution from 2010 to 2017. So after that, as I said during my introduction, we perform a multivariate analysis to assess factors that can influence the use of bed net among children under 5. And we noticed that there were no difference, a significant association found in residence area like rural and urban, and also among household health council also there were no association. But among region, as you see the previous slide, the region is a factor that have to be kept in attention when there is another conception of intervention in the future, because it's highly significant. And also we assess household modification, the way it's like we categorize like modern and traditional, and we found that children living in modern house were more likely to use than those living in traditional houses. So as I meant, region is a key determinant for mosquito net use in Togo, so it have to be kept in attention for further intervention conception. So as I'm like a weakness and strength of our study, so we can say that we use 3 different data sets I mentioned before in the method. So each of them were conducted in different seasons. So we were saying maybe this can also have like, it can affect our results, like it can underestimate or overestimate. So also the response during the survey was self-reported. So we were saying maybe it can be a kind of social disability bias as the survey happening in the household, in the community. So we said, okay, as a data set is a national scale data set, so it is also important to give a strength of our results we found. So, and in conclusion, as what we can take like home message is like, consider progress was made. Of course, we have seen that there is a lot of improvement in ownership, access, and also use. But there is still a way to go, because in access, we have seen that it's very low, having 1 mosquito bed net for 2 persons. So because the target is at least 80% in Togo, so there's still some effort to do. And also, they have also to keep in mind the regional difference, as I mentioned before, which is very important also for bednet use. So that's what we have to share with you. Maybe we can more go in depth in our results during our discussion. We thanks the participation of the study. We thank the founders and all those help us to have this data set today and be presenting you these results. So thank you very much for listening, and the time for question, and we will be happy to go in depth in our analysis. Thank you.
Thank you very much, Kombate. Again, another interesting study and findings, and a very good approach. I don't see much questions, but I may also start with a couple, actually. For you, Kombate, I quickly checked and see that there is a more recent mix, 2017. So probably you were expecting this question. Can you please elaborate a little bit about why you have chosen 2010. Yes, I also see that there is a MIS 2017, and maybe two questions in one. What is the preference of one mix over another, and what would have happened, I mean, if you put the recent mix? Maybe you already checked whether there were differences in terms of finding between the MIS 2017 and mix 2017. So regardless, I mean, this will need to be elaborated when this turns into article or a paper or whatever. So I just wanted to hear from you. Maybe we can start with that, and then for all attendees, again reminding you that you may insert your questions by using the Q&A button at the top of your screen. So please add. Otherwise, maybe Kombate, if you want to elaborate on that. Thank you.
Yeah, thank you very much for this question. We already had it. So yes, at the beginning of when we were starting thinking, we were saying maybe we can also use the one 2017, because that one data set is available online, but the recent one 2020 is not available. And we were saying, as we have a malaria indicator survey is the last one, maybe we can use that one. And yeah, in 2010, we don't have any data set apart from mixed. That's why we say, as we want to also, it helps us also to see the way the indicators are defined in each survey. So that's why we say, if we want to keep these three data set, so let's go with mixed 2010 and use demographic health survey and other one for 2017. Yeah, it will be really helpful to use the most recent one, 2020 in Togo, but the data set is not yet available online for us. Maybe for, I don't know, but on the UNICEF website is not yet available. So that's why. Yeah, but this question is very, yeah, I can say I already got this question. So we can also consider, as we are still doing things, analysis, we can also consider using it for having other better, maybe we can have better result than what we are having now. Yes. Thank you.
Thanks. The data is from 2017 survey is available.
Yes, yes.
Also the report.
Yes, yes, yes.
That needs to be kind of mentioned, elaborated a little bit, of course, with your justification to include, to not include. I'm sure you have already checked for that. Thank you very much, Kombate. And over to you, Nazim. If you have any questions, you can see.
Yep, there is a question from Paloma. So I think it's for the last presenter. Did you address your analysis for a complex data survey sample?
Complex data survey somewhere.
We cannot hear you. Oops.
Sorry, can you come again?
Yeah, the question was from Paloma. Did you address your analysis for a complex data survey sample? So
I guess, yes, that means, please, can you maybe explain a little? I don't really catch what.
Yeah, Paloma just added one more comment, weighting, strata, and cluster. So that's what she means with a complex data survey sample. So did you take into account in your analysis the weighting, the stratification of the survey, and clusters?
Yes.
Okay, Paloma, if that's enough. If not, please respond with another question if you have it.
But we only analyze for children under 5, not for the whole population.
And one more time, just to confirm that the Togo Mix 2017 data are available in our website. Yeah.
Yes.
I don't see any other questions, so over. Yes, it's a question coming from Justina. What is the structural difference between the traditional versus modern house that influence use of nets?
Yeah, we have seen there were like a kind of explanation for household type in the questionnaire. So we based on that, like modern household, like houses like those in cement, improved. We normally we said improved and traditional. So that's it. We based on that, not where the household is like rural or urban, but we took into account some characteristic, the roof, yeah, the floor. Yeah, we took into account many characteristics to when we were recording that variable.
Okay. There is another question. And again, for you, Justina, please comment again if you need more clarification. Next question is coming from Kuta Roland. Thank you very much for this presentation about malaria. Apart from the mosquito net use, what other mean do you think that could be effective, as the use of mosquito nets seems to be not popular enough? I have experienced malaria when I have arrived in Côte d'Ivoire 2 weeks ago. So, personal experience.
Yeah, maybe we can think about. Yeah, I also found that during our also discussion, we found that Togo there is a increase in the gross domestic product, GDP. So maybe it can help population afford a long bed net. Even now is free of charge for pregnant women and kids under 5. So it's helpful to it's not very expensive on the market, and so it can help for this like a kind of the first indicator ownership. It can be very helpful for that. But our results show that I'm talking about health control in household. I don't know. I'm not going to confuse with socioeconomic factors, but it's not significant for that in Togo context. So we can maybe say it depends in our context. Like region have a very huge influence, and maybe we were saying maybe we can add also a variable like a culture to see if culture also can have like a kind of influence on the behavior for using bed nets also. So as I said, we are still performing the analysis. So if there is a proposition, please, we can keep it and run again the model.
Okay, thank you. It seems that Roland is happy with the answer. So there is no other question that I see here.
Okay, yeah, I don't see any other questions. So thank you very much to both our presenters. These are really interesting and encouraging research studies, analysis, and we are looking forward to see more details about this and hope that we see similar studies for other countries as well. Okay, we received the last minute question, so over to you, Nazim.
Yeah, it's a question, a follow-up question coming from Justina. Thanks for the feedback. I was just wondering whether windows or other structure influence the use of the nets, and whether windows are different between modern and traditional house.
Yes. Yes.
So her question is, she's wondering whether windows influence or other structure influence the use of the nets. So
yes.
And yes, okay.
because we took these factors into account when we were recording these kind of things. Because if it's modern, it is well done. So yeah, it is like a kind of barrier, yes, for the population.
All right, we don't see any other questions, and we will probably finish earlier than scheduled. I hope that's fine. So thank you very much to our speakers and also co-authors of these presentations. And thank you also to all the participants and the questions raised. And thank you very much for joining. This is the penultimate session, one of the penultimate sessions of the mixed conference. So if you are planning to join the next session, which will be the closing one, it will also include the keynote speech that Attila couldn't do yesterday because of his flight cancellations, but he is here in Bristol with us, and we encourage you to join. If you are already registered to the Bristol University of Bristol Zoom link, which will start in 15 to 20 minutes time, and we hope to see you there. And thank you very much. Hope to see you in another event again. Bye-bye.
Thank you. Bye-bye.
Yeah, thank you. Bye-bye.